Everyone, today I am going to explain liver function test. Before that, you should know the basic anatomy. Liver having two lobes, left and the right. Left is the comparatively smaller as compared to right, and the right lobe is dome shape. On the posterior, there is the inferior vena cava which drain the blood to the right atrium, and the gallbladder inferiorly. Gallbladder, the main function of gallbladder is the storage of bile. Okay, bile is synthesized in the liver but the store in the gallbladder. The main function of bile is to emulsify fatty food. Whenever we eat the fatty foods, the bile is released from the gallbladder and emulsify, which help in the digestion of the fatty foods. Now come to the drainage system of the liver. Liver has having two ducts, left hepatic ducts and the right hepatic ducts. Left and right hepatic ducts combined with the cystic duct of the gallbladder to form the common hepatic duct. Common hepatic duct with again combined with the pancreatic duct. The yellow part is the pancreatic duct to form the common bile duct, and common bile duct directly drain into the first part of the duodenum. In this way, the bile and the bilirubin is directly drained into the intestine. Okay, why it is important? Because the bilirubin is unconjugated. It means the bilirubin cannot be easily excreted, easily expelled from the urine and the feces. For that, we have to conjugate that bilirubin. So liver having a special enzyme, that is UDP glucoline transferase, which conjugate that bilirubin and drain that bilirubin directly into the intestine. Okay, now this is the pictorial diagram of drainage system of the liver. You can clearly see left hepatic duct, right hepatic duct to form the common hepatic duct after joining with the gallbladder duct. Okay, it descend down and combine with the pancreatic duct to form common bile duct. Common bile duct directly drain into the first part of the intestine or first part of the duodenum. Why it is important? Because on the basis of this we can classify jaundice into the prehepatic, hepatic and the posthepatic. Posthepatic, what is the meaning? What is the meaning of jaundice? Jaundice is the yellowish discoloration of the sclera and the mucous membrane. Whenever bilirubin is increased beyond the normal physiological level, it's accumulated in the tissue, especially in the sclera, and it gives the yellowish color. When the bilirubin is formed, normal RBC is having lifespan of 120. After that, RBC's hemoglobin is break down into the heme plus globulin. Heme plus globulin. Globulin is reutilized for synthesis of amino acids, and the heme is converted into the biliverdin, and that biliverdin again converted into the bilirubin. Okay, that bilirubin goes into the liver for conjugation for easily excretion from the urine and the feces. It excreted from the urine in the form of urobilinogen and from of intestine in the form of stercobilinogen. Okay, so on the basis of this we can divide into the jaundice on the three different types. Prehepatic, whenever there is a excessive destruction of the RBC. So RBC destruction is directly related to bilirubin formation. As the RBC destruction increase, as in the case of hemolytic anemia, any types of hemolytic anemia like autoimmune hemolytic anemia or any causes of DIC, thalassemia, so there is a jaundice in the patient because there is a formation of excessive bilirubin, because at a certain limit or liver conjugate the bilirubin, but after that particular limit, the capacity to conjugate bilirubin is lost by the liver. So RBC destruction is the main cause of prehepatic jaundice. Come to the second point, that is the hepatic jaundice. What are the causes of hepatic jaundice? The main causes is hepatitis. In the children's and young person, the main cause is hepatitis A virus. In the congenital, in the neonates, the common cause is congenital biliary atresia. In the adult, the main causes is or hepatitis B or hepatitis C is mainly transmitted by blood disorders. So hepatitis B, hepatitis C on the chronic condition can cause to liver cirrhosis. Okay, alcohol is also a cause of liver cirrhosis. There are the many causes, but alcohol is the one of the causes of liver cirrhosis. So cirrhosis, hepatitis is the main cause of hepatic jaundice. Now come to the post-hepatic jaundice. Whenever there is an obstruction in the drainage system, first one is there is an obstruction in common hepatic duct, or there is an obstruction of common bile duct. Third one is an obstruction in the head of pancreas, or fourth one is an obstruction in duodenum. So whenever there is an obstruction, bile is not drained into the intestine, and there is a progressive types of jaundice, that is the surgical jaundice. Why it is called surgical jaundice? Because surgery is needed in this case to remove the obstruction. It is progressively jaundice, cannot relieve by the meditation, or cannot relieve by the medications, or cannot relieve by the taking rest or glucose diet. Okay, so we have to remove the obstruction. Obstruction may be in the form of bile duct stone, gallbladder stone, pancreatic head malignancy, or duodenal malignancy. Now come to the liver function test. Liver is having basically 5 function tests. First, biosynthesis. The main synthesis, liver main synthesizes proteins in the form of albumin, globulin, and the lipoproteins. Albumin is the major protein in our body, which is generally synthesized by the liver. Okay, second one is the metabolic regulations. Whatever we eat, it contains carbohydrates, protein, and the lipids. So liver play a major role in the diagnosis in the metabolism of carbohydrate, lipid, and protein. Third one is detoxifications. So main function of liver is to detoxify our body from the hazardous chemicals. So we eat protein diets, so there is a formation of ammonia and the many waste product which is excreted by the liver, that is the endogenous, and exogenous compound also detoxify by the liver. Fourth one is the secretions. Water soluble end product like a bile salt is secreted by the liver. And finally is the storage. Some vitamins B12, vitamins K are stored by the liver. Okay, now come to the liver function. So we can measure the liver function on the basis of these 4 headings. First one is the synthetic function, second one is the serum enzymes to know the status of liver injury, third one is the based on detoxification, we generally measure the blood ammonia level, fourth one is the hepatic excretion. So the liver bilirubin is generally excreted by the liver. So with the help of bilirubin estimation, we can know the excretory function of the liver. So on the in the synthetic function, we generally measure the serum proteins. Main protein in the serum is albumin, second most is the globulin, and the other like ceruloplasmin, haptoglobulin, alpha-1 fetoprotein, alpha-1 antitrypsin are measured on the specific conditions only. Another thing is the prothrombin time. Why we generally measure prothrombin time for synthetic function? Because the prothrombin is synthesized by the liver. Second one is the liver enzymes. There is the 5 liver enzymes which generally know the status of the liver. First one is the ALT, second one is the AST, which generally known as SGOT and SGPT. Third one is the alkaline phosphate. Fourth one is the gamma-glutamyl transpeptidase, and 5 is the 5 nucleotidase. These are the 5 enzymes which generally reflect the status of the liver. Third one is the taste. Based on the detoxification, we generally eat the protein in the diet. That protein convert into the ammonia, and which is generally excreted by the liver. So detoxify by the liver. So in the case of liver injury or the chronic liver diseases, the blood ammonia level is increased. Okay, that's why the ammonia level detoxification function of the liver is very important. And the fourth and the final most important is the excretory function, serum bilirubin, conjugated and unconjugated, which is also known as the direct and the indirect bilirubin. We generally measure total and the direct bilirubin. We generally subtract the direct bilirubin from the total bilirubin, and we will get the indirect bilirubin value. Okay, these are the routine liver function tests: albumin, liver enzymes, bilirubin, blood coagulation factors, and the marker of liver fibrosis. In very rare condition, we measure the liver fibrosis marker, like in congenital condition or any autoimmune disorders. Okay, so let's learn one by one. Test based on the synthetic function of the liver. First one is the serum protein, and the main serum protein is the albumin. The normal value of albumin is 3.5 to 5 gram per deciliter. Albumin generally synthesized by the liver, so it is very obvious that in the liver condition, liver disorders or chronic liver conditions, albumin level is decreased. So the main role of albumin is to maintain the osmotic pressure in the vessels. So as the albumin decrease, the osmotic pressure is decreased, and there is a formation of edema or ascites, development of edema and ascites in liver disorders. And half-life of albumin is 20 days. Next most important thing is the AG ratio, that is the albumin and the globulin ratio. Normal albumin is much more as compared to globulin, so 1.2 to 1.5 as compared to single 1 globulin. Okay, in the case of liver disorder, albumin synthesis decrease and the globulin synthesis is normal, so AG ratio is the reverse in the case of liver disorder. Is the serum globulin. So what is the importance of serum globulin? In case of serum globulin, normal value is 2.5 to 3.5 gram deciliter. Okay, there are some specific antibodies which generally increase in the liver disorder, like IgA antibodies increase in the alcoholic liver disorder, IgM antibodies in the case of primary biliary disorders, cirrhosis, IgG antibodies in the case of autoimmune hepatitis. So next one is the serum prothrombin time. Prothrombin time is measured by the automated machine, that is the PT-INR machine. Normal value is 10 to 15 seconds. In case of liver disorder, the prothrombin time is increased. So prothrombin time generally measure the extrinsic factor, extrinsic coagulation factors. So in case of liver disorder, there is an increased coagulation time because of the decreased production of prothrombin. Okay. Now next come to the serum enzyme. Second test is the serum enzymes. So the 5 main enzymes: SGOT, SGPT, alkaline phosphate, gamma-glutamyl transferase, and the 5 nucleotides. Okay, now come to the first, that is the ALT, which also known as SGPT, that is alanine aminotransferase, and the SGPT full form is the serum glutamyl pyruvate transaminase. Normal value is 13 to 35 unit per liter in the male, and the 10 to 35 unit per liter in the female. So normal source of these enzymes is liver, first most important. Second one is the cardiac muscles. Third one is the skeleton muscles. So muscle is the muscle, cardiac or skeleton, along with the liver is the most important source. So when these enzymes increase, mostly in the case of necrosis and the inflammation of the liver. So when there is a necrosis or inflammation of the liver, first one is the inflammation in the case of acute viral hepatitis. Any types of hepatitis, like viral hepatitis A, B, C, and the E. Okay, viral hepatitis A is the most common cause of jaundice in adults and the children's. Okay, and the hepatitis E is the most common cause of hepatitis jaundice in pregnant women. So when there is a necrosis in the case of toxins or any drug induced injury, toxin in the case of poisons. Okay, so this is the chart when we show the very high level, that is the 300 to 1000 in the case of acute hepatitis, like a viral or something drug injury, toxic or viral in origin, like viral A or viral B. Okay, moderate like a 500 to 100 in the case of chronic liver disease, hepatitis C or NASH, that is a non-alcoholic steatohepatitis. Okay, now come to the next, that is the SGOT, serum glutamyl oxaloacetic transferase. Normal value is 8 to 20 unit per liter. So source of this SGOT is also liver, muscles, and the myocardium, that is the heart. So these are the three sources of these enzymes, SGOT and SGPT: liver, heart, and the muscles. So the ratio of SGOT SGPT normal ratio is 0.8. So ratio more than 2 is important in the case of alcoholic liver disease, hepatitis with cirrhosis, and NASH. Generally alcoholic liver diseases in the alcoholic liver disease, ratio is always more than 2, and when there is a ratio decrease in the ratio in the, like less than 0.8 in the case of acute condition like toxins or acute viral hepatitis. Okay, so ratio more than 2 indicating alcohol induced injury. Okay, so next is the marker of obstructive jaundice. What is the where is the obstruction? So this one is the left or right hepatic duct which combined with the cystic duct of gallbladder, and finally to form the common hepatic duct it descend downward to join pancreatic duct and form the common bile duct. This one is the common hepatic duct. So whenever there is obstruction in this tract in the form of stone or in the form of malignancy, so the most reliable marker for obstruction is the alkaline phosphate. Normal level of alkaline phosphate is 40 to 125 unit per liter, and the normal source of alkaline phosphate other than liver is the bone, most important in the pregnancy, placenta and the intestine normal. So bone is also a rich source of alkaline phosphate. So there is a very high value like 10 to 20, 10 to 12 times increase in the value in the case of obstructive jaundice, and the drastically high value, that is the more than 12 times, is generally seen in the case of bone disorder, because the bone is also a rich source of alkaline phosphate. So there is an increased alkaline phosphate in rickets and osteomalacia, that is the bone disorders. Okay, next enzymes is the 5-nucleotidase. Normal range is 2 to 17 unit per liter. 5-nucleotidase is also an indicator of obstructive biliary disease or hepatobiliary disorders. So 5-nucleotidase along with the alkaline phosphate is the marker of obstructive jaundice. Next one is the gamma-glutamyl transferase. Gamma-glutamyl transferase normal values is 10 to 30 unit per liter, and it's generally increase in the alcoholic patients. So its level sometime parallel to the level of alcohol consumption. So alcohol consumption is directly related to increase gamma glutamate transferase. Okay, next one is the next test is a test of detoxification, that is measurement of blood ammonia level. Normal is 10 to 15 microgram per deciliter. So increase ammonia level in the case of cirrhosis, and there is a portocaval anastomosis. So these are the two main conditions in which the blood ammonia level is increased. So ammonia is very dangerous, it crosses blood brain barrier and damage to the brain. So that's why the blood ammonia level is more important in the case of liver injury. Okay, next is the test for excretion. So the excretion, we generally measure the bilirubin in the serum, bilirubin in the urine, and the second one is the urine and fecal urobilinogen and the bile salt. So we generally measure the serum bilirubin, total, direct and the indirect. Okay, this is the chart of bilirubin metabolism. So RBC generally break down into the heme again convert into protoporphyrin, biliverdin and the bilirubin, and the bilirubin it's combined with the albumin and enter into the liver. In the liver it is conjugate with the enzymes gluconide, UDP gluconyl transferase, because the conjugated bilirubin is generally able to excrete it from the liver. Its unconjugated bilirubin is not able to excrete from the liver, so it has to be conjugate before excretion. So what is the main function of liver? In the case of bilirubin, the main function is to conjugate the unconjugated bilirubin with the help of enzymes, that is the UDP gluconyl transferase. After conjugation it is excreted from the urine in the form of urobilinogen, and excreted from the intestine in the form of stercobilinogen. Okay, so that is the bilirubin metabolism, RBC destruction, formation of bilirubin albumin complex, conjugation of bilirubin and excretion of bilirubin from the liver. So come to the next, what is the jaundice? Jaundice is the most important, that is the yellowish discoloration of the sclera. Sclera is generally white part in the eye, which we generally seen. So in the case of increased serum bilirubin more than 2 mg per deciliter, there is a deposition of the bilirubin, and then the sclera, and the sclera suddenly turn from the yellow from the white. Okay, so after whenever there is an increase in the serum bilirubin more than normal value, it's deposited into the sclera, nail bed, mucous membrane, and after sometimes it get excreted from the urine. Okay, so jaundice. What is the jaundice? It's a yellowish discoloration of the skin, sclera, and the mucous membrane. So what is the critical value? More than 2 milligram. Remember one thing, it is not a disease, but it is a sign that something is wrong with the liver. The main cause of increased jaundice is the prehepatic, hepatic, or post-hepatic. So prehepatic causes is generally hemolytical anemias, RBC destruction due to any cause. Hepatic causes I had told you earlier: cirrhosis, viral hepatitis, toxins, drug. And the post-hepatic, that is the surgical jaundice, is obstruction into the drainage system of the liver. So whenever there is a jaundice in the patient, physician and the surgeon prescribe liver function test to rule out the causes of prehepatic, hepatic, and post-hepatic jaundice. Okay, so with the help of liver function test, we can able to differentiate prehepatic, hepatic, and post-hepatic. So basically, prehepatic causes a hemolytical anemia, hepatic is hepatitis, generally hepatitis viruses, hepatitis due to viruses A, B, and C. Congenital condition, rare congenital condition like biliary atresia or stricture in the bile duct. Post-hepatic obstructive jaundice, surgical is the gallstone, malignancy, or something inflammation. Normal value, bilirubin normal value is 0.2 to 0.8. Among this, conjugated is 0 to 0.2 and unconjugated is 0.2 to 0.6 gram per deciliter. So this is one the basic principle of estimation of serum bilirubin by diazo methods. In the serum, we add diazo reagent and add accelerator. Accelerator turn into the bilirubin pink color, and then we add alkaline tartrate. Alkaline tartrate turn into the blue color, and the intensity is measured at 600 nanometer, and we will get total bilirubin. The same method is applied for the direct bilirubin, except we not generally use accelerator at these steps. So we will get total and indirect. We generally minus direct from the total, and we will get indirect bilirubin. Okay, in this way we will get total, direct, and indirect bilirubin. Now how to approach the patient of the liver disorder or patient with the history of jaundice, sudden developed jaundice. So whenever there is a history of jaundice, we generally measure the serum liver enzymes level. So in case of, if the enzymes level is high, that is more than 300, it indicating acute liver disorder. So there is a 3 or 4 main causes of acute hepatic injury. First one is the hepatitis. Like in the case of hepatitis A, we generally measure antibodies IgM, anti-HAV. In the case of hepatitis B, IgM or HBsAg, that is the direct surface antigen. Okay, and third one is in the case of hepatitis C, we generally measure hepatitis C virus RNA or antibodies against the hepatitis C virus. In the case of alcoholic liver disorders, we generally, as I told you earlier, the SGOT SGPT ratio, that is normal ratio, is 0.8. In the case of alcoholic liver disorder, ratio is always more than 2. In the case of toxic injury, the enzymes level is too high, that is the 3000 unit per liter. Okay, normal value is 10 to 13. It's almost 100 times more than normal value. Okay, in the case of drug injury, we generally measure the markers for drug injury. Okay, now come to the how to approach the obstructive jaundice. First, we measure the alkaline phosphate. If the alkaline phosphate is increased, second most marker is gamma-glutamyl transferase. We can measure if the both the enzymes is increased, it indicating obstruction in the biliary drainage, liver or biliary drainage. If only alkaline phosphate is increased, it indicate that something is wrong with the bone. Okay, so if both the enzymes is increased, we generally do the ultrasound or CT scan to know the causes of obstruction. In the case of obstructive jaundice, If there is a no dilation of the bile duct, there is something is wrong in the liver. So look for liver mass or the diffuse liver disease. In the case of liver mass, just do the FNAC, we will get primary or secondary cancer. In the case of diffuse liver cirrhosis, diffuse liver diseases, in the cirrhosis, we just perform the liver biopsy. Now suppose there is a dilation of the biliary bile duct, so it indicates the obstruction. There is a extrahepatic cholestasis obstruction. We generally perform ERCP or the percutaneous transhepatic cholangiography to know whether there is a gallstone, carcinoma, or something wrong with the head of pancreas. Okay, thank you.